Hello, guess who? It's Beth Wright, and I believe this is your last podcast of NUR 236. Yay, yay, yay. I know you're happy about that. And we are in Unit 6, and we're going to be talking about drugs for hypertension, which is a very common thing that we see in our patient population for sure. So we know, let's talk about hypertension for a minute. We know that it's very common and it can be a chronic disorder and it affects a whole lot of people in our nation. Uh, it increases the risk of a myocardial infarction, of heart failure, cerebral infarctions, cerebral hemorrhages, and renal disease as well. As a matter of fact, if you talk with people who are on dialysis, some of them will tell you that the reason they're on dialysis is because of hypertension. So hypertension is usually defined as a systolic blood pressure over 140 milligrams of mercury or a diastolic blood pressure below or above 90. And systolic is where the heart is that beating, that the depolarization of the heart, where it's got the force of contraction, and the diastolic is where it's resting. We call the hypertension a silent killer. That's a name for it, because many times people will have hypertension and have no signs or symptoms at all. And it will surprise you when you take a little petite lady's blood pressure and, you would think, okay, so she's little, she's petite, that it would be a low blood pressure. And then sometimes it'll be out the roof. So it'll surprise you about individuals when you take their blood pressures. So the regulation of the blood pressure is the arterial blood pressure is what we're getting, and that's the force that's extended on or exerted on the arterial walls by the blood flow. And so we got to have two main things that's involved here: the cardiac output, which is your systolic pressure, and the peripheral vascular resistance, which is your vessels resisting that blood, and that is our diastolic pressure. And so we have to think about those two things. We also got to think about the cardiac output and what that is equated to, and it is your heart rate times the stroke volume, which is the amount of blood that's ejected from the heart and the heartbeat. So factors that affect it can be the cardiac output, the distendability of arteries. So if the arteries are not able to distend or dilate, then what happens to the blood pressure? We're going to have a constriction effect there. The blood volume affects it. So think about if we have too much volume in those vessels, what are we going to have? We're going to have hypertension, versus if we have too little volume in the vessels, then we're going to have hypotension. The blood velocity, or the force of the blood, is going to be an impact here, or a factor, and also blood viscosity, the thickness of the blood as well, because if it's really, really thick, then it's not going to move through the vessels like it's supposed to. So we have an auto-regulation that goes on. That's the body's ability to regulate that own blood flow, and it's primarily by nutritional needs of the tissue. We got to have oxygen for sure, and the metabolism of cellular metabolism of the byproducts that we take in our body. And other important factors are the histamine, the bradykinin, and the serotonin and prostaglandins. Those also play a part in helping to regulate the blood pressure. So the body, when we have a situation that's causing a hypotensive state, we have that sympathetic nervous system that comes into play, and the adrenal medulla secretes the epinephrine and norepinephrine, and we have that renin-angiotensin system that comes into play, where the angiotensin 2 and aldosterone are formed. And when the aldosterone kicks in, you know that we hold on to our fluid by the kidneys. We retain the fluid and salt and excrete the potassium, and that increases our blood pressure. Now, when we have a hypertensive situation going on, the body responds and it increases the renal secretion of fluid, and of course we have fluid loss, which equates to a decrease in the blood volume, and that impacts the cardiac output to go down, which impacts the arterial blood pressure to go down, and then in effect causes our blood pressure to go down. So hypertension is a persistent high blood pressure that results from abnormalities in that regulatory mechanism that we just talked about. And again, it's systolic pressure over 140 and diastolic over 90. Now, primary hypertension, about 90 to 95% of the cases are primary, and things that can be a part of that primary are genetics, obesity, high alcohol intake, the insulin resistant patients, a high salt intake, age, cigarette smoking, sedentary lifestyle, stress, and pain. And then secondary causes may be because of the renal issues, or maybe some renal disease, endocrine problems, central nervous system issues, or from possibly from medications. Now, this is from the American Heart Association. It gives you what they recommend or what their standards are for blood pressure reading. You know, what is pre-hypertensive for both systolic and diastolic pressures, what is considered hypertension is stage 1, and then stage 2 hypertension, and then of course the emergency care needed higher than 180, or the diastolic higher than 110. So why are we concerned about hypertension? Because it works the heart. It overworks the heart for sure. It increases that cardiac workload. You know, anytime we overwork a muscle, you know what's going to happen. They get hypertrophied, and you know, anything that is enlarged like that, it's not going to beat well, and eventually heart failure can occur. So initially, it may not produce any symptoms at all, but when it does affect, you know, symptoms, or start having to have symptoms, they will be of the target organ damages. And you know, the target organs for hypertension is heart, brain, kidney, and the eyes. And you know, again, it's a silent killer. You may have somebody that goes to get their eyes checked, and you know, not diagnosed with hypertension, and the ophthalmologist says, hey, you've got hemorrhages in your eyes, let's check your blood pressure here, and lo and behold, they have hypertension. It's often discovered after a person experiences angina, or myocardial infarction, heart failure, stroke, or renal disease. Our symptoms can include, they do have symptoms, severe headache, nausea, vomiting, visual disturbances, any kind of neurological problems such as drowsiness, stupor, or coma. And then we get into the hypertensive emergencies, you know, where you definitely, if something's not done, an organ is going to be affected. and immediate blood pressure reduction is needed. But when we do that, we can't do it too fast. We got to do it slowly, and it's usually with IV perennial antihypertensive drugs to given to limit the damage. And these hypertensive emergencies, it's typically an extension of malignant hypertension or cerebral hemorrhage, a dissecting aortic aneurysm, or renal disease. And again, the symptoms, severe headache, nausea, vomiting, level of consciousness decreased, those kinds of things. And we got to move on that. Okay, there are drugs out there that can increase blood pressure too, so we need to be aware of that, and it's important to get a good history of the patient, and what meds they're taking, and also what diet they're taking. So appetite suppressants can increase the pressure. Certain diets can. So think of diets that can do that, like too much caffeine, mochas, chocoholics. Nasal decongestants can cause hypertension, birth control pills, NSAIDs, and corticosteroids, because we know those corticosteroids can cause us to retain fluid, which will then, cause us to have an increased blood pressure. So here are our exemplars: ACE inhibitors, angiotensin 2s, receptor blockers, that's our sartans, alpha 2 agonists, beta adrenergic blockers, alpha beta adrenergic blockers, diuretics, and direct acting vasodilators. And we have talked about these medicines already, but we're going to talk a little bit more about them. So our main goal here is to get the blood pressure down below 140/90. If we can't get it down that low, at least getting it down some is going to help. Also, we want to, talk with the patient about weight reduction if they're obese or overweight, sodium intake reduction, regular physical activity, moderate alcohol intake, and smoking cessation for sure. So, I've worked with patients regarding hypertension, and, one lady in particular is in mind, and she was morbidly obese. And her blood pressure was running around 190/100. She was having some symptoms for sure. She was having a severe headache. She was having, some definite problems, visual disturbances. And so, I was talking to her about, we got to get this down. We got to get the pressure down. She goes, I think I want to, I want to try to lose the weight before I go on any kind of medications. And so I started talking to her about, okay, that's fine. That's your decision, but here's what can happen. It can cause you eye damage. It can cause you kidney damage where you would have to maybe go on dialysis. It can cause you stroke. So when I, started talking with her about all those things, she's like, okay, we'll get on the blood pressure medicine, and I'll work on losing the weight at the same time. I was like, thank you, thank you, thank you. So the management guidelines, factors to be considered: age, because the older we get, the things don't work like they did. Vessels don't work, the heart doesn't work, so lots of things don't work like they did at one time. Ethnicity can play a part. There's certain ethnic backgrounds that have a genetic tendency toward hypertension. Any concomitant or cardiovascular disease orders that's going on at the same time, like, an MI or heart failure, or a coronary artery disease, and they have heart or hypertension at the same time. So the thought is to start the medicine at the lowest dose, and if the change medications groups instead of increasing doses if the first medicine that is tried is ineffective. Now, there are lots of medicines out there, and we need to really encourage patients, if they're having side effects, don't stop the medicine. First of all, talk to your doctor about it. And there's many different medicines out there that can be tried to control the blood pressure. The main thing is they don't want to have the hypertension where it's affecting those target organs. Um, and we titrate those medicines based on the individual response of the patient. So our antihypertensive meds, we got the ACE inhibitors, the angiotensin receptor blockers. We have the anti-adrenergic medicines too. Now this class of medicines, the way it works is it lowers the pressure by dilating the blood vessels. And of course the downside of these medicines is it can cause sedation. So for safety reasons, they're better to administer those meds at night. They're pretty potent. And if a patient misses a dose or abruptly stops the medication, they may experience rebound hypertension that was worse than what it was when they first started medications. Calcium channel blockers, diuretics, and we have the direct vasodilators as well. So these medicines affect two factors of blood pressure, is dependent on the cardiac output and the peripheral vascular resistance. So let's talk about our ACE inhibitors once again. And you see these medicines have the pril at the end of them on the generic name, and that's what you need to know. Again, these are that renin, angiotensin, aldosterone system. That's what this affects. And they are awesome drugs to use for blood pressure, not only because they cause dilation of the peripheral blood vessels, but they also decrease blood volume by decreasing sodium retention and water retention. So remember, it affects that renin, angiotensin, aldosterone system that occurs. So that's what it's blocking here or inhibiting. It can cause a first dose hypotension, so we need to warn a patient about that for sure. It can trigger angioedema, so we got to teach the patient if they have any kind of swelling of the tongue or the mouth, they need to let their doctor know ASAP, and they're not going to be able to take ACE inhibitors again if that happens to them. Since the ACE inhibitors prevent retention of sodium, we know that the kidneys are going to retain potassium, okay, instead. So we've got to monitor those potassium levels, and to prevent potassium level to increase, we probably need to talk to the patient about not using salt substitutes. So we've talked to them about not using salt, and a lot of people tend to go to the salt substitutes, which are potassium chloride, and so we need to talk to them about they do not need to use that. This medication is contraindicated with the bilateral renal artery stenosis. It should be administered 1 hour before a meal, and it should be taken, like all antihypertensives, the same time every day. Adverse effects: cough is a common thing, a persistent hacking, non-productive cough, and it won't respond to any kind of cough medicine. It's just a side effect to it, and it may be to the point, if it's really, really aggravating, the patient may not want to take it. It can also cause agranulocytosis, meaning the white blood cells will go down. So what do we need to check on the patients, and what do we need to tell them about that? They need to let us know if they have any kind of sore throat or anything like that, or a fever or anything. Also proteinuria, so we need to check the urine for protein, and glomerulonephritis it can also cause. So that's another sore spot, if you will, for ACE inhibitors. We want to prevent interactions, of course, and so it may increase that serum concentrations of DIG and lithium, so we got to watch about that. Again, talk to them about the salt substitutes because it can cause that hyperkalemia. Um, when dose is adjusted or adjusted, it is administered and or adjusted. It is necessary to always assess the pulse and blood pressure. And adverse effects, we want to check that blood pressure to make sure they're not getting a severe hypotension or severe bradycardia. Check for the cough and also the serum potassium levels as well. And women of childbearing age needs to take something to prevent pregnancy. Our angiotensin II receptor blockers, our ARBs, if you will, notice they have that sartan at the end of the generic name there. And it's used, of course, for hypertension. And African Americans, these medicines may be ineffective if they're used alone. If sartan is used alone, does not control the blood pressure, then a diuretic may be added. These medicines can also cause angioedema, so we need to be teaching the patient about that. Also dizziness, muscle cramps and weakness, heartburn, diarrhea. Decreased sensitivity to touch can be a problem as well. And pregnancy is contraindicated. And of course we need to assess for adverse effects, and we need to monitor the renal and liver function as well as potassium levels for these, because again it works with the angiotensin part, so it's going to be that same thing about the potassium retaining instead of excreting. Okay, our alpha 2 agonist centrally acting, and your medicine there is clonidine. The agonists decrease the outflow of sympathetic nerve impulses from the central nervous system to the heart and arterioles. And so that results in slowing the heart and conduction, velocity and dilation of the arterioles. The alpha 2 adrenergic agonist crossing the blood-brain barrier has a hypotensive effect and are sometimes called the sympatholytic or centrally acting hypotensive drugs. They can cause sedation, dizziness, and sexual dysfunction. It's rare, but it can also cause hemolytic anemia, leukopenia, thrombocytopenia, and lupus. So, because of all those side effects, you may not see these prescribed as much. For safety reasons, because of the sedation, we want to give those at night. Again, they're pretty potent. We've got to tell the patient if they miss a dose or abruptly stop the medication, they may experience rebound hypertension. So we got to be sure to talk to them about that. The clonidine is available in transdermal patches, and they are worn for a week. They can be made like little tiny patches, like fingertip size. So, got to look for those patches on the patients. Anytime you're putting those patches on, look for the older ones, because if they're little like that, you can certainly miss them. Now, our beta adrenergics are OLOL medications. Those are our beta blockers. And usually these aren't used alone, especially with African Americans who don't benefit at all from beta blockers by themselves. And so they work better when they're taken with a diuretic. So those medicines, the propranolol, atenolol, metoprolol, those are the ones OLOL at the end. They are drugs of first choice for people younger than 50 with the high renin hypertension, tachycardia, angina, MI, or left ventricular hypertrophy. And then we have our alpha beta adrenergic blockers, and those are the LOL at the end of it. Carvedilol is one of them. And these are used to treat heart failure, left ventricular failure, and high blood pressure. And it's funny, when you talk to patients and you see what medicines they're on and stuff, and you'll say, okay, now are you on this? What are you on this medicine for? And they'll say, that's my heart pill. And it may very well be their heart pill. It may not be for hypertension. So, because many of these drugs, as you know, treat other things, other issues of the heart. Then we have our diuretics, and you've talked about diuretics. You need to go back and look at those. But, in moderate to severe hypertension that doesn't respond to diuretics alone, it may be necessary to add an antihypertensive drug. So a lot of times you'll see a diuretic and a antihypertensive drug. Remember about your potassium-sparing diuretics, your spironolactone. It can cause hyperkalemia, so we do need to be checking the potassium level for those patients. Other vasodilators, we have the nitroprusside or nitropres. And so again, they're vasodilating, and these are given continuously IV for emergency situations. So it's going to require frequent monitoring of the blood pressure, and the intra-arterial blood pressure monitoring is the best way to do that when given this. The drug breaks down first into cyanide and then thiocyanate acid. Isn't that kind of scary sounding? So anyway, it shouldn't be given longer than 72 hours because of that. And those drug levels need to be monitored when the patient is on this. Otherwise, a patient can be toxic and get cyanide poisoning. But, these medicines work directly by relaxing smooth muscles in the vessels, and that results in dilation and a decrease in the peripheral vascular resistance. That nipride is very potent. It's short-acting. That's titrated as an IV drip. That you can only use that, only dissolve that medication in D5W. The bag or the bottle of this medication has to be protected from light, and so you'll see different ways the pharmacy may have them, aluminum foil wrapped or in a dark plastic bag. And you got to use an IV pump for this, and of course monitor that blood pressure frequently. The minoxidil can exacerbate angina and precipitate pericardial effusion, which can progress to cardiac tamponade. So we've got to be concerned about that. So teaching for antihypertensives, we got to talk to the patient. Don't stop your medicine abruptly, especially some of those that can cause the rebound hypertensive situation where it's higher blood pressure than what it was when they first started medicine. They need to make those lifestyle changes, work toward them, avoid the high sodium diet, control the weight and fat intake, exercise, avoid smoking, the drinking alcohol as well, and all of those things may help with improving the blood pressure. We got to talk to the patient about checking their blood pressure. They should be getting, a blood pressure monitor, and they need to, of course, get an accurate blood pressure reading, and using the correct size of the cuff is going to be important, and to have the patient relax the arm, not to hold it in midair. And not to take it after they've been exerting or, after they've had a cigarette. So we got to teach them about these things for sure, so they'll know that. And they can take it, they should take it at the same time every day. Before morning and evening meals maybe would be a good time. And to write it down so that they can bring the readings to their healthcare provider so that someone knows how the medicine's working. We also want to, teach them about signs and symptoms that they may experience, the dizziness or fainting, and the orthostatic hypotension. So they got to move slow when they change positions. Wearing elastic stockings can help that peripheral vascular part of it. Exercise the legs, avoid prolonged standing, avoid hot baths. If dizziness occurs, they need to sit or lie down to prevent a fall. And, you know, another thing is other side effects, like some of these medicines will cause sexual dysfunction, for instance. Um, you know, a lot of times patients don't like to talk to us about that, but many times they'll tell nurses things that they won't tell their doctor, or they'll just stop the medicine. So we got to be sure to talk to the patient about their medicines, and you know, if they are experiencing any kind of side effects, because again, there are so many ones out there that the doc can try different medicines for them. We need to teach them also about over-the-counter meds, because some of them will have things that can cause vasoconstriction, and some of those cold medicines and things like that. So they need to talk to the pharmacist about that. Also, specifically the losartans, we have to teach about avoiding salt substitutes, and the clonidine patches to, you know, apply those to hairless areas on the upper arm or torso once every 7 days, and to be sure to rotate those sites. Now, we talked about various ethnic groups, and so that is the case when we're caring for individuals. And you'll see in the reading the discussion about children, because we are finding that children are having hypertension at an earlier age, which is unfortunately because of our epidemic of obesity. Definitely renal impairment and hepatic impairment is going to make a difference with your medications, so be sure to note those specifically. Patients who are undergoing surgery, that's something that's definitely needs to be discussed with the physician and anesthesiologist or the surgeon. Do they want the medicines given, you know, before they go to surgery? Sometimes they do, sometimes they may say no. Depends on the type of surgery as well. Critical illness, for sure, we have this treatment going on a lot with hypertension and in the critical care area. You know, also your dialysis patients, you know, need to talk to your practitioner about that, as far as typically they do not want to give your antihypertensive medicines before a patient goes to dialysis, because the dialysis procedure lowers the blood pressure. So we need to hold those medicines until the patient gets back. Home care, again, we've got to do a lot of teaching to the patient, lifestyle things, medicine issues, and also herbal and dietary supplemental use. Need to talk to the patient about that, because there are several herbs that will interact with these medications. All right. Thank you.